Hi there, my name's Donna Gairns. I'm a Lymphoma Care Nurse with Lymphoma Australia. I'm just going to do a run through of some about Lymphoma Australia and some of the work that we do, and then looking at a little bit of an overview of lymphoma. Lymphoma Australia is the only solely dedicated charity for lymphoma in Australia. We do a lot of work with awareness, so attending national and international conferences, significant lymphoma meetings across the country, and also having a bit to do in collaborating with other organisations who are linked with lymphoma, such as the Lymphoma Coalition, who are an organisation made up of 60 different countries across the world advocating for patients with lymphoma. We also collaborate with government and other associated non-charity or charity organisations, and also with pharmaceutical companies to help ensure that the best information is getting to patients and health professionals across Australia. We provide support, online support through our support groups, and phone support with our lymphoma care nurses, ensuring that every patient, carer or health professional has access to a lymphoma care nurse regardless of where they live in Australia. We also do advocacy work, working with pharmaceutical companies and government to try and ensure that the best treatments are available for lymphoma care for lymphoma patients in Australia. We promote and advocate for the best research and clinical trials also to be available in Australia by doing submissions to various organisations. We provide education through education events, live events. We do webinars that you can access through our website. We produce patient support resources through hard copy, through booklets, and our fact sheets are available online to download or to print, or you can give us a call and we'll send them out to you. And we also provide regular newsletters for both patients and nurses across the country as well, keeping everyone updated on the latest in lymphoma. We understand that lymphoma patients are dispersed right across the country, not just in the metropolitan areas, but also through our regional and rural areas across Australia. And not every patient is referred to a large lymphoma specialist centre. Some patients are referred to smaller cancer centres through the rural and regional hospitals, and also through private practice as well. So we recognise that sometimes there's an equity of expert advice and education and support for lymphoma patients across Australia. Not all patients always have access to the best clinical treatments and clinical trials, but at least we can help facilitate and point you in the right direction, all patients. Our lymphoma care nurses provide awareness, advocacy, support and education for nurses and patients across the country through our attendance at national lymphoma-related conferences, meetings and events. We share current and best practice in management of lymphoma and improve patient experience and helping to improve survival outcomes. And we're in a position to help drive change through best practice for lymphoma patients in Australia. We collaborate with national and international committees, organisations, government and pharmaceutical companies to ensure that we have the most up-to-date information and help advocate for the lymphoma patient and for health professionals across the country. And we also provide clinical advocacy for the Pharmaceuticals Benefit Access Committee submissions for new treatments that might be being brought into Australia. We help develop patient resources, both online and also in hard copy as well. We have booklets which can order through our website, or print or download them from our website as well. We have fact sheets we're continually updating and putting out on our website, which you can print and download for free. And these are on various subtypes of lymphoma and also other things such as exercise or transplants and treatments and things like that. We also have regular newsletters, not just for patients but also for nurses who can access these through our website or through our groups. And we try to keep our website up to date as much as possible as well. The Lymphoma Nurse Support Line is a free line that anyone can call anywhere across Australia. Patients, carers, or health professionals. If you have any questions in regards to lymphoma or trying to get the right information, or we can try and find the information for you. And it's a service that operates Monday to Friday through business hours, and if someone doesn't answer the phone, that they can just leave a message and we'll get back to as soon as we can, or by emailing our inquiries line through our website. We have a Lymphoma Nurse Special Interest group, and this is growing in numbers quite considerably over the last 12 months. And as of June 2019, we have almost 650 nurses across Australia through all states and territories, and also New Zealand. We have a dedicated online portal which you can access and sign up for through our website. And this is where we can hold information, international guidelines, surveys, new medications from pharmaceutical companies, guidelines, that sort of thing. You can access it through our portal, or alternatively you can get onto our private Facebook group, Lymphoma Nurses Down Under, which is a platform where for nurses be able to communicate with each other, ask questions, share information that you might have come across through your research across the place. And it's also a site where I put any news that comes across from across the world, I'll put onto there as well. We have a Lymphoma Nurses Down Under newsletter, which I put out once a month, and this is a monthly roundup of any new applications, webinars, videos, podcasts, whatever I can find, we put onto that site, so make it easier for you to be able to access the best and most up-to-date information without having to search for it yourself, because I know how busy it is from working on the wards to be able to keep up to date. And there's so much information out there with 80 different subtypes, it can be very hard to keep up to date. I also put out a 3-monthly newsletter, Nurse News, which is a roundup of any updates in Australia, new medications that might be put onto the pharmaceutical benefits scheme, or education events. We might do a highlight of a different subtype each 3 months, just relevant information you might need to know. We do education events across the country as well, and we're hoping to increase these over time, and we look forward to some feedback on those through our nurse survey, which we have through our nurse group, to be able to see what you want and how we can best support you. We have various education events for patients and nurses across the country, education days, and we keep you up to date once you've signed up onto our newsletters. We'll keep you up to date with anything that comes up across the country. We have international guest speakers that from time to time come to Australia, and we help advertise and support education through these sessions. And also including obviously our local speakers. We have some of the world leading haematologists and health professionals throughout Australia. And a lot of these we record these sessions on and put them onto our website too, so you can access them at a later date. We have support groups for patients, and Lymphoma Down Under, we have about 1,500 members on that site, and it's a good way for patients and carers to keep up to date with each other and have that peer support, which we find is a great comfort for most people. Lymphoma Australia, we also of course on the Facebook page, we also have Instagram, Twitter, and our videos are all on YouTube as well. And we also can sometimes put you in touch with other people with local support groups in the various states. These come and go, but we can, if we know about them or you want to make one, we can at least advertise that for you. So we've currently got a carer and nurse surveys, as I mentioned briefly, the nurses, but we also have a carer one at the moment to see what patients and carers want, and making sure that the services that we are providing at the moment cover what you need, including the nurses too, so how we can improve our service and help improve our support for nurses too. So now I'm going to go a little bit about lymphoma and the incidence in Australia and the sort of patients that we're covering and the sort of work that we're doing. So in Australia, last year alone, there was over 6,400 patients that were diagnosed with lymphoma. And in Australia, it's the 6th most common cancer in both men and women, or about the 9th overall. So we sort of look down the list, so sometimes awareness and education and knowledge can be differing. So that's hence our organisation. It's the most common cancer in the 15 and probably up to about 30 years of age group. And it's the 3rd most common cancer in the 0 to 14 years of age. So hence it's a disease that shows no boundaries with age, and there are over 80 different subtypes. So it's 80 different separate diseases, all form underneath the one banner. And some of these are extremely rare as well, where you might have 1 or 2 patients in the whole country that may have some of these subtypes. So many different subtypes, some of them are rare, and also the combination of patients, no matter what age, can get one of these sort of subtypes. It's a very important group to be aware of. And numbers are doubling over the last 20 years too. We're not too sure exactly why, but a lot of research and thought have gone into that too. So as I mentioned before, it is the 6th most common cancer in Australia for both men and women. And so it is quite significant, but because we usually fall behind some of the more common ones, awareness, and a lot of people still don't know enough about lymphoma. And because we cover 80 different diseases, it can be quite an overwhelming subject to keep up to date with. The 5-year relative survival for lymphoma patients are generally pretty good, especially some of the more common ones, where we're looking at almost 80% for some of the, say diseases such as Hodgkin lymphoma, indolent lymphoma. People can live with that for many years, and some of the aggressive lymphomas and CLL, people can, over your 5-year survival is still quite good. But some of these are extremely rare as well. Incident mortality by age and sex. Obviously, as we get older, like with a lot of other types of cancers, lymphoma does increase with age generally, and also obviously mortality as well as we age too. And that's about the same with men and women. Looking at the hematopoiesis tree, the lymphomas do come from the lymphoid stem cells. So our blood stem cells, so we'll start from the start. Our blood stem cells are our main base cell, and they can turn into any type of blood cell that our bodies are needing at any given time. So some of them will develop into myeloid stem cells, where they then develop into red blood cells, neutrophils, platelets, that sort of thing. And what we're looking at with lymphomas is when they develop into the lymphoid stem cell lineage. And these cover different cells such as our B lymphocytes, our T lymphocytes, and natural killer T cells, which make up some of our white blood cells. So it's really important to sort of understand where lymphoma comes from, so then we can understand how the disease progresses, and also some of the ways that we treat lymphoma. So lymphocytes are looking at what they do. So basically we have 2 different types of immunity, our innate and adaptive immunity. So our innate immunity are our like our neutrophils, who are first on to the response for any infections or abnormal cells to fight infections. Our lymphocytes are a part of our adaptive immunity, and this just means basically they're pretty much they're very, very important in our immunity, where they start building like antibodies, and some of our T cells are like killers for fighting infection and cancers in our body. So they're more slow responses, but they're really quite important in making sure our bodies are able to keep fighting infections and abnormal cells in our body. So as I mentioned, lymphocytes are a part of our adaptive immunity. They develop in our bone marrow. B lymphocytes are stored in our lymph nodes predominantly as part of our humoral immunity, so they secrete antibodies and they neutralise any pathogens or infections that invade our bodies. And they bind to specific antigens on the outside of viruses and bacteria to help then produce the antibodies to better fight that infection. We then have our important T lymphocytes that come along, and they're stored mainly in our thymus, which is here, and sometimes in our tonsils. And they're part of our cell-mediated immunity, and they protect our body from things such as infection and cancer. So they run around and destroy anything that looks abnormal, or cells that might be infected by an infection, bacteria, or abnormal cancer. So they can usually recognise these cells and kill. So they're very, very important in our body's immunity. Understanding lymphoma, it's important to understand what it is. So lymphoma is basically a cancer involving the lymphatic system, and this includes our B and T lymphocytes. So our lymphatic system branches out all through our tissues, so it's going to keep moving, goes all through our tissue and branches out into all parts of the body. And the main roles of it is to drain excess fluid from body tissue and filter and return the rest of our fluid back to our bloodstream. It also is an area where it stores the specialised white blood cells in our lymph nodes, the lymphocytes, and that is to help and fight infection. So we've got lymph nodes all throughout the lymphatic system, which helps stores those. So lymphoma is basically when the lymphocytes gain a DNA mutation, and then therefore they uncontrollably grow, and eventually they cause swelling in the lymph nodes and your spleen, your bone marrow, and sometimes your blood, and it weakens the immune system after a while. So basically lymphoma is given a name given to a group of cancers and 80 different subtypes of those, and these numbers we're getting growing over time as well, which I'll go into shortly. So basically it causes the swelling and lumps around our body. So some of the lymphoma signs and symptoms can vary for patient to patient. Some patients, they may not have any symptoms. They might have been accidentally diagnosed from a scan for something else that they might not be expecting. And sometimes patients might get a painless lumps in various parts. Generally they can feel them when they're around their neck, in their chest area, under their arm, and in the groin area is the most common areas we can feel them, but they can occur obviously anywhere in the body. Unexplained weight loss can be a symptom of patients getting tests and diagnostics to be diagnosed. Drenching night sweats can occur. Itching for no particular reason that can't fix, and generalised fatigue are some of the main symptoms that patients might go to their GP, and sometimes they might go to their GP multiple times before they're actually diagnosed. I mean, we sort of forget that it is actually still quite a rare cancer, and quite often it's more likely because of an infection or something like that, but over time patients might have come to the GP quite a number of times before diagnosed. I'm going the wrong way. So what causes lymphoma? Basically we're not too sure what causes lymphoma overall. Generally there's an unknown cause, but the majority of cases there's no family history. And some of the more higher risk factors, patients may have had an infection with Epstein-Barr virus or EBV, or been exposed with human immunodeficiency virus or HIV. They think, and this particularly rings true in some of the more skin lymphomas, where a court case recently found that Roundup, one of the pesticides, probably the cause of some of the cutaneous skin lymphomas. But chemical exposure can be sometimes seen as a high risk factor that can cause some of the cancers. Fertilisers and solvents and other sort of chemicals that people interact with can cause. Previous organ transplant, this can cause a lymphoma, and this generally is because of some of the immunosuppressants that patients go on after a transplant can then obviously alter their immune system, and they get a secondary cancer, which is unfortunate. And some autoimmune disorders such as rheumatoid arthritis can be a known risk factor for some of the lymphomas. So overall, lymphomas can be grouped, and this is where it gets getting a little bit confusing. So we can have non-Hodgkin lymphomas. These account for about 90% of all lymphomas, and these can be both B and T lymphocyte mutated lymphomas. And then about 10% can actually be known as a Hodgkin lymphoma. And this is a type of lymphoma that has the presence of a certain cell called a Reed-Sternberg cell, which was discovered by a gentleman called Thomas Hodgkin back in the 1800s, which is quite a large, easily recognisable for pathologists looking down the microscope to see this cell. It's quite a large, like an inflammatory type cell. B cell lymphomas are the most common of all lymphomas. These make up about 85% of all lymphomas. There's roughly around about 60 different subtypes, so it's really important for patients to, when they get diagnosed, is to understand exactly what subtype you have, because they're all completely different characteristics, and it's important to understand that and why you might be different to that person next to you in the chair. T lymphocytes, T lymphomas make about 15% of all lymphomas. There's roughly about 450 people in Australia per year are diagnosed with this, so they're very incredibly rare and can be quite aggressive and very hard to understand a lot of the time. And that makes up about 20 different subtypes, and some of these are extremely rare, like maybe one patient in Australia, one or two in Australia every year might be diagnosed. Since 2016, the World Health Organization reclassified lymphoma, and once upon a time, before this time, there was only about 45 different subtypes, but as the powers of be and the smart people around, the haematologists, understanding the lymphoma more and more and how these different subtypes and genetic differences some of these subtypes have, the numbers have now increased. From 2016, it was about 60 different subtypes, and this is not to read, basically just to give you an idea, there's only half of them, to give you an idea that there are a lot of different subtypes and how quickly the area of lymphoma is changing. And actually since last year, in 2018, then it's been reclassified again, and they think it's about over 80 now, and that's just going to probably increase over time as well, as they're starting to understand what makes lymphoma tick, basically, and how it grows and looks under the microscope and acts. So that I'm sure will increase. So the most common subtypes of lymphoma you'll probably come across in your clinical areas. Diffuse large B-cell lymphoma makes up around about 30% of all lymphomas and the B-cell lymphomas, and that's usually classified as more of aggressive lymphoma, followed by follicular lymphomas, about 25% of lymphomas, and this is quite an indolent lymphoma or a slow grower. We'll go through that a little bit more in a moment. And sometimes those lymphomas can transform into a diffuse large B cells. This is where it all gets confusing. Chronic lymphocytic leukemia is now classified as a lymphoma, and the point being that it's very similar to small lymphocytic lymphoma, and they're essentially the same disease. Just like chronic lymphocytic leukemia is probably more found in like a high white blood cell count in your blood, whereas and seen that way, whereas the SLL is more in the lymphatic system, you'll find. And that makes up about 25% of cancers. And all the rest is sort of very rare from there on, but it's good to know that there are, at least know where to realise that there are many different types, and they all act very differently, and sometimes very hard to understand and different characteristics. So B cell lymphocytes, this is giving an idea, this diagram basically, to show that lymphomas are categorised or diagnosed from different parts of the cell that is abnormal. So you'll see here like mantle cell lymphoma is quite an immature B cell subtype, right through to the more mature cells. So hence that's where a lot of these lymphomas get given their name. And there's a bit of a difference between Hodgkin and non-Hodgkin lymphoma. I guess the main differences are that Hodgkin lymphoma is probably about 15% of all lymphomas, and it's made from a particular cell. Most patients are in adolescent and young adult age, and there's another spike in age greater than 55. But the differences between non-Hodgkin and Hodgkin's is that Hodgkin can quite generally be spread in quite an orderly fashion through the lymphatic system, and it's a better, easier to stage and best predictive prognosis for knowing where it is as well, and you can usually understand how it spreads. Whereas a non-Hodgkin lymphoma can be a lot more disorderly in its fashion, and sometimes might come with some B symptoms, but it can be quite a big array of different classifications and how they act as well. Classical lymphoma is generally, Hodgkin lymphoma, there's 4 different main types of classical lymphoma, Hodgkin lymphoma, and there's another slower growing nodular lymphocytic predominant Hodgkin lymphoma too, which has an excellent prognosis, which we won't go into too much. but just know that there is a difference between these different subtypes too. So again, it's important to know what your patient's subtype is to understand their disease and therefore give them the right information. Non-Hodgkin lymphomas can be anything from very slow growing, generally incurable lymphomas, through to very aggressive, fast growing and very variable prognosis compared to Hodgkin lymphomas, which is generally an excellent prognosis. So that's pretty much the difference between the two of them, but they're very different. As we're going, we're probably more pushing away from calling lymphomas Hodgkin lymphoma, non-Hodgkin lymphoma, rather than calling it by the subtype, so patients do understand that the different characteristics of their actual subtype and the treatments. But for practical groupings, when we're diagnosing a patient, we're looking at putting them into groups such as aggressive, low-grade, indolent lymphomas. And how this will help us in our treatment of them, basically the faster the growing the lymphoma, the more need for treatment and the more greater the curability by giving like a chemotherapy regimen generally. And this is because the faster the growing the cancer, the quicker, the easier it is to kill the chemotherapy kills the cancer. In the more low-grade indolent lymphomas, therefore they grow a lot slower. The need for treatment's a lot less, or not as urgent. So some patients might live for many years with the disease without needing treatment until they become symptomatic, and generally it's less curable as well, because quite often the disease comes and goes or gets treated when you're symptomatic, and then they'll eventually, unfortunately, come back. So we sort of group them into different gradings. A lymphoma diagnosis is done by ultimately a physical examination, so understanding where the lymph nodes or what symptoms the patient's experiencing, getting a good medical history, certain blood tests such as FB, UNE, LFT, looking at their clotting profile, lactase dehydrogenase showing how sort of fast the cells are growing, and getting a good viral screen as well, so you know exactly what you're dealing with your patient. A biopsy is the most important. It's needed to confirm a diagnosis and to ensure that we get the correct diagnosis for a patient to give them the correct treatment too. And staging scans are also highly important, PET scans, CT scans, and occasionally MRI, but not so often. And sometimes, depending on the certain type of lymphoma, they might need a lumbar puncture to get a full picture of what's going on. So ultimately, diagnosis is done with tissue. So they need to remove a good chunk of tissue, and this generally means by getting, most people need like an open biopsy, taking the whole lymph node out, so they get a good chunk of tissue to be able to get a good diagnosis. A lumbar puncture to sort of see again what's going on, and also maybe sometimes a bone marrow biopsy as well to see whether the disease has spread into the bone marrow to get the full pictures for certain types of lymphoma too. And just talking about the biopsy, that's why unfortunately some patients may have originally had a fine needle aspirate, and that's just the biopsy that's taking a very, very small amount of tissue, and quite often that's not enough needed to be seen under the microscope. Patients need quite often generally a good core biopsy, so a good chunk of tissue like the width of a matchstick, or getting the whole lymph node cut out, and that can be quite frustrating for some patients too. So just about explain that to them, why they're needing a whole lymph node, because they need quite a big chunk of tissue. So then they look under the microscope, the pathologist, to see what the cells look like under the microscope, so they can tell whether it's normal or abnormal and getting a good idea. They then do what's called flow cytometry, so where they put some of the tissue into a liquid and then pass it through like a laser, where they can then pick up genetic markings on the outside of the cell to sort of see what type of cancer cell we're dealing with, because all cells project different proteins on the outside of their cell. That's part of diagnosis. They're then looking, putting through another couple of brilliant machines, very expensive machines basically, to see what other genes are expressed on the outside of a cell and getting a genetic expression profile to know exactly what type of subtype they were dealing with. For instance, diffuse large B-cell lymphoma, there's 5 known subtypes, but they've known, there's some studies they've done where they've put 1,000 different patients some genetic profile expressions through a machine, and each patient might be completely different or have slight differences with each other. So not every diffuse large B-cell is a single disease, is where that slide comes from. So there's a lot of different subtypes, so making sure we've got the right subtypes, so then they're actually able to treat it in the right way as well is very important. This slide just shows that, especially a diffuse large B-cell, we'll keep with the same theme, that there are about 5 known different subtypes with diffuse large B-cells. So before recent times, they realised some patients weren't doing as well as other patients, for instance. So now they know that there's different subtypes they've recognised, and at diagnosis it's very important for them to, a part of their prognostic workup is to determine which one they're dealing with. And there's 2 different types. There's germinal centre B-cell like diffuse large B-cell lymphoma, and there's also the activated B-cell like diffuse large B-cell lymphoma. And the ABC generally has a little bit lesser good prognosis as such as the GCB subtypes. That's very important in the initial stages of diagnosis. There are other types of diffuse large B-cell out there as well, which we call triple hit and double hit. And basically these are other subtypes of diffuse large B-cell lymphoma that are characterised by recurrent cytogenetic rearrangements and expressions on the cells of lymphoma. And the 3 different subsets that they've recognised, mutations they've recognised of recent times, and they look at diagnosis, is the MYC rearrangement. So our MYC is important in regulating, all cells have it, regulating roughly about 10% of our human genes. And they influence the cellular proliferation, the DNA and protein synthesis and metabolism. So they're really important by down-regulating our cell cycle inhibitors. So it's really important how our cells grow and divide and stop and start. There are also another 2 cytogenetic rearranges, our BCL2, which regulate our cell death or apoptosis, or our BCL6, which regulate the germinal centres, activating and survival, the DNA damage and response. So basically they're all very important in how our cells grow, die, stop and whatever. So once there's a mutation in any of these, or double hit, there'll be a mutation in the MYC in either BCL2 or BCL6, and the triple hit will have all 3. This can usually show that there's a worse prognosis in these types, and we might need to treat them a little bit stronger, or just being aware of it, that we might need to, that patient might need some further treatment down the track. That's why you might hear people talking about these hits. Other things that are required in diagnosis part is the PET CT scan. And this is a part of our staging to sort of determine how fast spread the cancer is. So stage 1 is one spot on one side of the diaphragm. Stage 2 is 2 different areas on one side of the diaphragm, can be up around the neck area or can be down below. Stage 3 is 2 sites above or below and one site on the other side of your diaphragm. And stage 4 can be spread to other different organs and widespread throughout the body. So this just gives us an idea of how advanced the disease is, and particularly with Hodgkin lymphoma, so it determines quite often the type of treatment we might be treating someone with. And even with someone with stage 4 disease, doesn't necessarily mean they've got a worse prognosis. It might just mean we might need to hit them with a little bit more chemotherapy. So in part of our staging as well, we might be looking at sort of what sort of additional symptoms a patient might have, and this is particularly runs true in Hodgkin lymphoma. So if you see a patient with a staging, so there might be stage 2 or 3, and depending on how many sites in the body, then we'll be looking at other symptoms. So if the patient is a stage 2A, it generally means they've got 2 different sites of disease, and then they might not have any other sort of symptoms. B symptoms, so it's just someone say where they've got 2B diagnosis. It means they've got 2 different sites of disease and they've got B symptoms. And this includes symptoms such as unexplained weight loss of greater than 10%. That's if someone generally is not trying to lose weight over 6 months. Unexplained persistent or recurrent fevers and temperatures of greater than 38 in the previous month, and really quite recurrent drenching night sweats where the whole bed is just totally drenched for no particular reason, you're not unwell or over a particular amount of time. And this just basically means generally the disease is a little bit more advanced. The patient might need a little bit extra treatment. And if you see something with an E beside it, generally means the disease is not quite localised. It's might have gone to different parts of the extranodal or outer lymphatic system, so including your liver, spleen or bone marrow. So it just gives a part of the prognostic and diagnostic staging. We'd also be looking at other international prognostic index scores, so looking at the age of the person, looking at some of their blood count, what stage they're at, and looking at how their performance status is. So if they're physically ailed, they might affect their treatment that we might decide for the patient. Other treatment decisions that need to be collated, obviously the subtype of the lymphoma we've got from the patient, knowing the classification and the grade, so how fast it's growing, so whether it's an indolent or aggressive lymphoma. Looking at the genetic profile, so just checking to make sure there's no particular mutations for certain types of subtypes that might hinder the patient's prognosis, and the staging. We're also looking at other blood tests, including the LDH and FBE, the age of the patient, whether they're coming with any other comorbidities, and especially with our older population, they may be coming with other illnesses, so we need to take that into account before giving them some high-dose chemotherapies, and the general health of the person, or the ECOG score. Looking at what sort of intention we have for the patient's treatment, whether we're going for a cure, whether we're going just for disease control, or we're going for palliative, so trying to reduce any symptoms or prolong the person's life. And obviously we're looking at the patient choice as well. Lymphoma treatment, this is where it's really expanded over the last few years particularly. This is a really good diagram of the different timeline for lymphoma treatments, where we had, since the introduction of rituximab, prior to that only other treatments were more chemotherapies, and autologous transplants came in, stem cell transplants came in about 40 years ago. But since 1997, rituximab has really revolutionised how we treat lymphomas and helped the prognosis of many different types of lymphoma too. And over the last 5 years, we've really exploded on the market with different immunotherapies, targeted therapies, and it's an exciting time for lymphoma. I mean, in the last 2 years, there's been 13 new immunotherapies being put on the PBS for lymphoma patients. So it's getting out of control, and it's an exciting time. So it's just more just to realise that there are lots of different treatments coming about. So treatments, we're quite often going for a curative, whether it's curative and curable, or going for localised. They could be for advanced treatments, for advanced disease. Sorry, it keeps moving. It might be for patients who have refractory disease, so disease that won't go away after the one line of treatment. We're looking for treating patients with relapsed disease. And we give treatments, generally it's usually multiple drug regimens over time. And we can give treatments either via IV therapy, subcutaneously, oral tablets, or sometimes topically in a cream. The most gold standard for a lot of sorry, it keeps moving. A gold standard for a lot of the treatments that we do is chemotherapy still, and still remains that, and it still cures a lot of patients. Sometimes patients might need radiotherapy if there's more localised sort of disease, or to help some stubborn disease that patients may have. Immunotherapy has really exploded over the last 5 years, meaning there's a lot more drugs and there's a lot more, and that's where a lot of the clinical trials and how we maybe combine that with general standard chemotherapy. And these drugs still have their own toxicities as well. And in immunotherapies, we have monoclonal antibodies such as rituximab or Gazyva, and Gazyva is the new upgrade of rituximab for certain types of lymphoma. Targeted therapies, where there's different tablet forms of immunotherapies that patients can have and work on the cells differently as a molecular interfering with the cell's pathways and how the cells redevelop and stopping them in their tracks basically. And there's also things like PD-1 checkpoint inhibitors, which are basically kickstarting and restarting our immunity and our T cells to start doing the job that they should be doing. And a current one, or latest one that's been approved in Australia is CAR T cell therapy. So just briefly, that is a exciting era where the patient can have their T cells removed. They're taken to the lab, they're supercharged basically, and then reinfused back into the patient to then help kill the cancer and do what it's supposed to do. And there's other antibody drug conjugates and stem cell transplants that can be delivered to patients as well. So the future, finally, with lymphoma is the future is genomics. So a lot of, as scientists are starting to understand lymphomas better and what makes lymphomas tick, they're realising there's more and more genetic mutations and ways that they can discover these at diagnosis. So the future, what we'll probably be looking at, is getting a diagnosis of lymphoma through a biopsy, of course, and staging, and this will include like a genetic sequencing to understand the genetic makeup of that particular lymphoma. And this can actually sometimes predict whether patients may go better under one line of treatment rather than another type of treatment. So this can be really quite important in future of maybe the best way to treat patients and individualise patient care and treatment. So the patient then might get treatment. If they go into remission, that's great, but if they relapse, then they might do another type of test as well, just to see whether the tumour's mutated again. And this can just help us target the therapy and the mutations that the doctors might see under the microscope will then determine the next lot of treatment for the patient. So it's a very exciting time and becoming very individualised treatment care. So thank you. It's a lot of information in a quick spiel, but at least it gives you an overview of lymphoma, how we diagnose lymphoma and the importance of that diagnostic staging phase for patients. It might seem like a long time for patients, but it's getting more and more important, especially in the lymphoma world, to have a true understanding of what type of lymphoma, the subtype the patient has, and before we actually go ahead with treatment, because that can help them along their way and help their prognosis as well. And for nurses working in the area, it can be really quite a challenging time to keep up to date with all these new medications that are coming about. We're all very used to treating patients with chemotherapy and understanding chemotherapy side effects. So it'll be quite challenging. Some of these immunotherapies, new targeted therapies are coming out because they're coming with a different side effect profile and new challenges of how we educate our patients and ensuring they have the right information that they need. So please give me a yell at any point in time if there's any questions or you're requiring more information. I can help you out as best as I can. Thank you.